Thank you very much, Norm. So I'm going to give a little bit of a background on, I guess, the theory. Some of you may know that the New Zealand smoking cessation guidelines are also changing at the moment. Unfortunately, we don't have anything to show you just yet. Some of you have seen the drafts, but hopefully by the end of the month we'll have something. And I'm pleased to say that we've also managed to reduce these guidelines from the 56 pages down to a sort of trifold 6-sheet, just tell us what to do kind of thing. As you can see, I've got a number of different roles, both here and in the UK. Now, this is pretty simple, and I'm going to give you just a little bit of background because it's not just your job, of course, to change smoking prevalence and help people to stop smoking. There are other things that have to happen at the same time, especially if we're going to get to smoke-free 2025. And this is Professor Robert West's law of smoking cessation, which is indeed not rocket science, and many of you hear me say that numerous times. But the number of ex-smokers in the community is simply a product of the number of people trying to stop in the first place and the success of each of those quit attempts. I think our primary role is still to try and get people to give it a go. No matter how many times they've tried before, they've just got to keep on going. Obviously, those that have perhaps tried 50 times before, you'll hopefully be able to provide them with some sort of support to help increase the success of that outcome. Okay, so there's two arms there. Now, the quitting process, as I said, is not just about you guys. It's about the whole sort of community-based approach. This is where we want people to get to abstinence, not smoking at all. And there are individual and environmental factors that are going to have an effect on both steps between smoking and making a quit attempt, and then that quit attempt becoming successful. Comorbidity is certainly something to consider here. If you're looking at people with mental illness, they have some of the highest rates of smoking and find quitting particularly difficult. We've got tobacco control policies that impact on both of these pathways as well. When we're looking at the sort of ABC approach or AB offer of C, it really has the biggest impact here. It's in prompting quit attempts, not necessarily increasing the success of individual quit attempts, because that really comes with adoption of smoking cessation support. And we often talk about these tensions, triggers, treatment. It's really important that, of course, we continue all these other environmental policies, price increases. You heard the Minister talk today about tax increases. These must continue to prompt people to make behaviour change. Treatment. We have options. We're very lucky here in New Zealand. But supportive environments are also crucial in helping people remain abstinent. And I just want to, this is relapse curve that's associated with unassisted quitting. People still quit in this way, and most people will still use this way to quit smoking. Okay, so it's not about deterring people from just giving it a go, but knowing that with additional support you can increase quit rates, but we don't have any magic cure. And I think certainly just handing out scripts for nicotine replacement therapy, for example, is really not going to have a big impact. And we're also already seeing in the UK that over-the-counter NRT is appearing to be ineffective. So these medicines are by no means any magic cure when it comes to smoking cessation. Okay, so the role of healthcare professionals, I think it's pretty straightforward, and you all know this. It's about identifying people who smoke, motivating a quit attempt, for those that want assistance in quitting, referring them on for support, and supporting ongoing abstinence. And that might be as simple as, how did you get on with that quit attempt? Or how are you getting on with your smoking? Now, I just want to touch on brief advice. This has sort of been a bit of a nuisance, this whole brief advice thing, because we all give brief advice. I don't think anyone here would ever now ask someone if they smoke, and the person says, yes, I smoke, and you go, good. It just doesn't happen. You're going to do this as part of your everyday practice, and you've probably been doing it for years and years and years. When it comes to recording brief advice, it's a bit of a strange thing to do. We give advice on lots of things all of the time, and recording it is not really quite what we do. And I really want to emphasize that we've got to focus on the clinical outcomes of this whole ABC pathway. And by that I mean if you make an offer of treatment and someone accepts it, then you make the referral or you do whatever that they want to accept. And if they decline, then you can say I offered but they declined. So it's less about documenting brief advice and more documenting the outcome of the intervention itself. And I'm going to leave that to John to talk more about. But the evidence behind brief advice is still the same. It's still, the main effect is by prompting people to give quitting a go. It does increase long-term quit rates, small, but on a population level, 3 percentage points is pretty good. And if you want a number needed to treat, it's around about 33. It depends on the baseline or background quit rate. Now I'm just going to show you a number of slides from Robert West's Smoking Toolkit study. Now this is an ongoing study, it's longitudinal, and they follow up a cohort of people who smoke and don't smoke over time. And advice from healthcare professionals are still the key external driver to making a quit attempt. What you say is incredibly important. And I know you'll have people come back and they've stopped, not stopped, and you think, why do I even bother? But it's important to keep on bothering and keep on doing this. And it's the offer of support that's important. So again, these data from the Smoking Toolkit study, and you can see there the only intervention that's effective in prompting quit attempts here, above the background quit rate, i.e. that in those that didn't see a GP, is the offer of help to quit. And this is where the new guidelines or the revised guidelines have changed, and it's more a focus on make an offer of treatment as opposed to just give brief advice to stop smoking. Okay, so this is the sort of new emphasis is I'd like to help you stop, or there are different ways, or I've had patients that have stopped smoking using this particular service. Would you like to give it a go? So hopefully a little bit more clinically focused than just brief advice. The new guidelines, by the way, are going to be called the New Zealand Guidelines for Helping People Stop Smoking. We've ditched cessation, and it's going to be in very plain language. And Heather, I'm glad I remembered to say that. Now, just a point here about not giving advice or making an offer of treatment. Now, this is showing you the odds of making a quit attempt, and the comparator here is not seeing a GP. Now, if you see your GP but that you don't get advice to quit, then you're significantly less likely to make a quit attempt. Now, this sort of fits with a lot of the qualitative data we know, and there was some work done by the Royal College of Midwives with pregnant women who smoke. And essentially, these pregnant women, if they didn't get asked by their midwife or offered support, they assumed that they were useless or not worthy of help and support. And some work that Grace Wong's doing is showing some very promising results too in terms of patients, what they want from their frontline healthcare professionals. And people do want your support in helping them to quit. So again, some more data here showing it's the offer of treatment that people want, not just, you need to stop smoking. And I think this is the way in which we sell this that's important. You could go through a sort of checklist approach and ask about smoking, and they say, yes, I smoke. And you say, well, you really should quit. Brief advice done. Do you want help in stopping smoking? Yes, no. And people sort of say no, because what is it that you're trying to offer? You've got to be a little bit more motivational than that. And I'm going to finish off here just by pushing this point. You don't need to assess readiness to quit. We have states of behaviour. Our behaviour can change very, very quickly. And these data here from a study conducted a wee while ago, and I know many of you have seen this slide, but they took just over 2,000 smokers and they asked them, are you ready to quit in the next 30 days or not? Now, most people said they weren't ready to quit. Here's 89% in the blue bars that said they weren't ready to quit smoking. Now, in the good old days, if someone said, no, I'm not ready to quit smoking, you would have left it there and said, okay, that's fine. But what they did in this study is actually they gave or made an offer of treatment to everyone regardless of what the patients actually said. So everyone got an offer of treatment. Now, as you'd expect, more accepted the offer of treatment, half, roughly, of those that were ready to quit. It just goes to show that not everyone's going to accept your offer all of the time. That's just how it goes. So don't feel disheartened if people say, no, I don't want this. But just to point out that a quarter of those that said they weren't ready actually decided to take up the offer of help to quit. So if you're looking at where the numbers are over on this side. So you don't need to worry about sitting down and going through and asking if people are ready to quit. Make your offer of treatment, do it well, be motivational. Some people are going to say no, that's fine, you can ask them again next time. But you'll be surprised perhaps about how many people might try something that's new. Now, implementation of all this best practice is a completely another story, and I'm going to hand over to John McMenamin to cover those things.
Thank you, Hayden. So the health targets, we're probably fairly familiar with health targets in this room because that's what we deal with when we're looking at primary health care from a population perspective. So we're familiar with this, and indeed we are working towards trying to improve these health targets, and we've been challenged this morning from the Minister to lift our game in this area. And as you can see, these are the results over the last couple of years showing that for the health target for asking people and offering advice in primary care, we're now up to 66%, and various areas are doing differently, and we've got some presentations today that will show us what's actually good practice. But what does it actually mean for people who are at the front line offering help to people to stop smoking? The targets are relatively irrelevant to them. What they're interested in is what's actually going to make a difference to their patient. So what we know is that a lot of people are being offered brief advice. If it's at 66%, then it means that over 300,000 people last year were actually offered advice to stop smoking and support, which is a wonderful thing. That's a very large number of people, and we know that that's going to translate into some effective outcomes. But what does it mean for me in my day job as a GP? We know that we're being asked to help people stop smoking. What is it that we do in primary health organisations and in the various networks and support processes to actually make that happen? And essentially we know that there's kind of three things that are necessary to encourage GPs and practice nurses to engage in offering brief advice, offering support to help people stop, and yielding an outcome with cessation. And the first one is that actually needs some kind of reminder to make sure that it's going to happen. So there's several different kind of reminder systems. These are reminders that come up on the clinical notes when you have a patient in front of you. The one on the left-hand side there, that's a dashboard reminder, and what it will show you is if the person hasn't been asked about smoking, it'll be red, and it's a prompt that says, yes, please engage with smoking cessation with this person, and reminding them. The one on the right is the patient prompt. Most areas in the country will have one of these kinds of reminder systems, and if they haven't got one, they definitely need one. It's very difficult to remember to add this into the already busy space of general practice without some kind of reminder. The second thing is that there's another population another way of looking at the population of people that come into general practice. There's those that come in, and obviously we're going to engage in the consultation room, but then there's the population that come in any one day. And what we know is that it's possible to use a tool like an appointment scanner that will go through your list of appointments for the day and tell you these are all the people that are coming in who are smokers with whom you might like to engage. And that means that where there is difficulty with remembering or being able to fit it into the consultation, we have other options. So, for example, a practice can look at the appointment scanner and say, today we have 4 smokers coming in to see John McMenamin. John's going to deal with 2 of them, but the practice nurse is going to deal with the other 2. So there are ways of actually addressing the needs of people who are differently coming in to see us, both in the consulting room and in a planned way. And the third one is that we need to be thinking about the third population, and that's the population of people that are not coming into the practice. So how do we know who those people are? We know who they are if we actually code all the smoking consultations. So the reason for coding consultations, and this is what we need to be sharing with primary care practitioners, with GPs and practice nurses, is not just that it actually helps that individual person's record so you know that they have actually had the advice, but that you can identify who hasn't been asked. And then you can use your audit tools, and there's different kinds of audit tools out there that will identify, for example, who hasn't been asked, and then those are the people that can be contacted. And is it worth contacting them? Absolutely yes. We know from research evidence that at any point in time, at least a third of people are engaging at home in some kind of interest in stopping smoking, and about 2/3 over a year will have a serious go at stopping smoking. And this is borne out by the context that we have with our outreach programs. If you send out texts or you send out, you make phone calls to people, on average you'll find around about 20 to 25% of people definitely want to engage in smoking cessation at any random point in time. So we know that smokers want to stop. We don't just want to deal with people that come into the surgery, we want to actually address the whole population. And the goal for us involved in organising around primary care is, whose job is this going to be? Clearly, this is quite a big task, because on these audit lists you find large numbers of people, and that's where, as organisations, we have to have a strategy. How is it that we're going to support practices to be able to contact these people? Are we going to be actually going into the practice and supporting them? Are we going to be asking them to do it? Are we going to be doing it from call centres ourselves? Some of these activities are short-term and can't be sustained long-term, so how do we make this business as usual on a long-term basis? So there's kind of the three opportunities we've got to really challenge this. Addressing it in the consultation room and making sure that there are reminders for people to do it, thinking about who's coming in the day and whose job is that going to be, and then looking at those that might not get asked, and how do we reach out to those people. And of course the whole purpose of this is to actually yield an outcome. I mean, the reason that we're making offers is because of the equation that Hayden put up before. The more people we make offers to, the more people will engage in smoking cessation, and we know that there are good outcomes from smoking cessation. For example, on the right-hand side here, we have the referral tool to Medtech, to Guideline. We know that at least 25% of people that engage in Guideline will stop smoking over a year. So it's if we can get people into the process, the more people we get in, the more successful quits that we've got. We know that if we engage with people smoking cessation ourselves as GPs and practice nurses, if we have local services, local quit clinics, if we have an Alkati program, we know that if we can get people into the program, that there is a really good success rate, and that people will actually actively become ex-smokers as a result of that. We know that this is starting to happen. This is the report from Guideline about the number of people. The red line there is people who have been referred in through the Medtech, so that's GPs doing electronic referrals. Something is happening out there that is increasing the number of referrals. We need this line to go up way more, because we know that any number of referrals is going to increase the number of people that are successfully quitting. And of course it has been successful. This is not new work. This work has been going on now for quite a long period of time. It builds on the back of all the background that's been going on in primary care for many years. It builds on the background of the hospital work, and it very actively over the last several years, the primary care target has focused a lot of attention from the minister, from the ministry, from the health promotion agency, from primary health organisations, from the National Heart Foundation, in general practice, all of us really aligned to achieve this goal, and we have reduced the number of smokers by 23% in the country. We only have 15% of adults smoking now, so that's a huge reduction in the number of smokers. And effectively, if we're going to be starting looking at, that's supposed to be 2025 down the bottom there, if we start looking at we want to be smoke-free by 2025, do you realise that's actually only 15 quits per GP per year? That's actually not very many. It is an achievable target, and a target that we can move to. Only want you to look at the top line here. This is the reduction in tobacco use, and you can see that in the last couple of years there's been a significant reduction in tobacco use in New Zealand. So we are having an effect, and this is actually a really important important message to get out to GPs, that they have been encouraged to offer support, they've been encouraged to engage in smoking cessation. They need to know actually that we're actually selling less tobacco in New Zealand as a result of that, and that every year 300 million fewer cigarettes are being smoked. So we're having quite a significant effect, and it's an important message to feed back to practices. So the summary part of this is we want better help for smokers to stop. We want them to quit by 2025. Brief advice and cessation support, or as the new guidelines will say, brief offers of help, because not only has that been shown to be more successful, but actually sits much more comfortably with us as clinicians. We want to offer people help. We don't want to be waving the finger at them and telling them what they ought to do. We know that there's over 450,000 smokers that we want to be offering this to. So this is our target population. 15 per year per GP. What we have to be thinking about in this room is how do we support those practices to ensure that they can get those 15 people per year to stop by 2025. And if we do that, we'll have reached our target. And it is just interesting to look back and think, this started like well into last century. The middle of last century was when this first became aware, but it's really only in the last few years that this amount of work has been happening, and it's in the last couple of years that as organisations, primary health organisations and related supports, that we've been supporting practices to actually make it happen. So I would just really like to support the whole focus of what this conference is about, and particularly interested in hearing from the PHOs who are reporting on innovation and ways, and I know that we have the PHO here who is at the top of the league table there at over 90%. We need to find out what's happening so successfully there and to be able to share those ideas elsewhere. Thank you very much.